So what do you think? I mean, $1 billion. If an industry says, hey, we're losing $1 billion on something, maybe we should, what's going on? Why is there such turnover? I mean, no doubt, joining a medical practice is kind of like getting married for the first time. You're going in there bright-eyed and bushy-tailed, but a lot of times the organizations are already preparing for the divorce, with contractual agreements. But we have to really address why there's turnover to begin with. Why are people not staying? And it really affects healthcare. Robin, any thoughts on that?
I'm not sure why all this money is being spent, but it seems like it's a roller coaster or a runaway train type situation.
And then, to go along hand in hand with this, an article that I stumbled on talks about North Carolina, basically workers at a FQHC, that stands for Federally Qualified Health Clinic in North Carolina, called Piedmont Health Services. And the workers here, the medical providers, are trying to unionize doctors, nurse practitioners, PAs. And their biggest issue is not pay. I'm sure they wouldn't mind some more pay. But for the most part, they say they're okay with the pay. It's their working conditions. So they describe a scenario having to see a new patient in a 20-minute slot. And these are, it's a FQHC, so these are an underserved population. There's a lot to address with their health concerns. And they're just kind of saying, we just can't do it. We can't do it and provide adequate care. And the organization that they're working for kind of has not been listening. So they're trying to unionize about it. Isn't that interesting? So it's not pay; it's working conditions in healthcare. Like this was a factory from 1850.
Well, do you disagree?
No, I don't disagree. We talked a lot. We say that healthcare is a volume-based business. I don't. I have to look at the economics of the FQHC, but my guess is they probably get paid per visit. So if they get paid per visit, they're going to want to see as many people as possible. And how do you do that? Well, you could expand hours. You could shorten the visit, cram more people into the time that they're there.
What do you think the layperson listening to this show thinks about that? You think they're happy to hear that it's a volume-based business and that get them in, get them out as fast as possible?
No, I think it upsets them very much. I think it upsets them very much. Although I think that it's a complicated problem with multiple causes and potential solutions. So some of them, for example, is patient driven. We talked about the need for convenience. I call my doctor and I don't know. I went to urgent care instead or things like that. So it has multifaceted issues pertaining to it.
I mean, I work at a restaurant. We want as many people to come in and have dinner as possible. But if the restaurant is full and there's no more tables open and you're waiting an hour and a half to eat, are you going to stay there? Or is this something that you're going to put up with?
Yes, I mean, some restaurants, are so good that people go there expecting to wait an hour and a half. I think that happens with some of my specialty colleagues. Patients go and they expect to wait, and they, in a way they're not happy about it, but they accept the wait because they know they're going to go see this highly in demand person who's worth the wait. Kind of like, waiting an hour or an hour and a half at your favorite kosher deli in Manhattan.
Okay, and usually that doctor will give you as much time as you need, or
maybe
they're scheduled an hour to deal with a patient they're meeting for the first time.
Sometimes there are other practices though where it's not like that, but the point is that sometimes the patient just is ready and willing to wait, just like you go to a restaurant that someone's ready and willing to wait.
So what is
other times they're not.
So what is the scenario? So then you're McDonald's, where you go and it's not as good, and you're not expecting it to be as good, but you want it fast and you want it right away.
Right. It's. I wish I could understand where this came from, and I think it was developed to apply to the restaurant business. But 3 issues something can be cheap, something can be convenient, and something can be good. You could have 2 out of 3, but you can't have 3 out of 3, and that's true. We think about it. Something can be cheap and convenient, like fast food. Doesn't mean it's not good for you. Something could be good and convenient, but maybe not so cheap, like other restaurants like Panera or whatever that are more expensive, but also kind of easy to get in and out of. Or something could be
fast and good
and cheap.
but not convenient.
Right, and to me that is, like a to extrapolate over to medicine, like a concierge doctor. You could have a concierge doctor. It's going to cost you a lot of money, but that doctor will potentially, be there, pretty quickly when that's what you're paying for. So it does apply to healthcare. Cheap, convenient, good. You got to choose 2 out of 3. You can't have 3 out of 3. You and I, on this show, have implored patients to be patient with their doctor as well, and it's a two-way street. Yes, I'm going to go into my office, in about an hour, start seeing patients. I'll probably see about 20 patients today, give or take 2 in either direction. I will probably review anywhere from 50 to 75 messages. Most of them are refill requests. A lot of them, not
lab results, test results.
There's some forms for me to sign. It's that need to be reviewed. So, it's a lot of work.
And potentially the chance of you running behind because of your own volition, or running behind because a patient arrived later than they expected to. And you understand that, don't you? I mean, people run into traffic or
they're just human beings.
They're just human beings. Things happen.
If I see 20 patients today and each patient shows up 5 minutes late, do the math. That's 100 minutes. That's an hour and 40 minutes behind. Yikes.
I ran into a patient of yours not too long ago.
Oh.
And we were having lunch with your mom. And she asked how his appointment had gone with you and if he had to wait. And he said, no, I never wait. I make the 1:00 appointment.
That is good advice, actually.
But everybody can't have the 1:00 appointment.
You might wait a little bit for your 1:00 and or first thing in the morning, first thing in the afternoon is 10. You'll be closest on schedule, yes. So yeah, it's tough, and so this idea of healthcare as a business, it's a business model, it's flawed in many ways because it's even though there's similarities to customers at a restaurant or somewhere else, I mean there's differences, if someone at a restaurant wants their hamburger cooked differently, they'll send it back and you'll cook it better. If someone in my practice wants a test ordered, for example, that I don't think is proper,
or that's not covered.
And, that kind of happened recently with a calcium score. Calcium scores tend not to be covered. Well, it turns out some insurances are starting to cover it, but it just got so complicated, when I ordered this test, I usually say it's probably not covered, and then it's kind of like, well, doc, can you call this number? Can you appeal it? Can you send a letter? Can you change your documentation? So that's a lot of work, and I don't want the patient to have to pay for something if insurance is willing to cover it, but I can't, it's very hard for me to figure out what
the insurance wants from you.
Yeah, it was a weird scenario. It's probably worth talking about sometime, calcium scores, because they're going to become more common over time. All right.
I was just going to say that the lipid tests are very uncommonly covered completely on your blood test.
No, that's a good point. So you're talking about a plain old lipid panel, and then there's more involved lipid panels.
Can you explain what the lipid panel is?
That's cholesterol, basically. It's also triglycerides, and people are a little confused. I call it the good, the bad, and the ugly. So with cholesterol, you got good cholesterol, self-explanatory. You have bad cholesterol, self-explanatory. And then you have triglycerides, the ugly. What does it mean? That's kind of, you ever see The Good, Bad, and the Ugly, old Western? What a great movie that is. With Clint Eastwood. Yeah. Eli Wallach. Anyway.
So what's the good?
The good is called HDL. You know, it stands for high. You generally want the high to be high, so it's right there in the name. The bad is LDL, which is low. Most treatment guidelines are based around either the ratio of total divided by high cholesterol or the LDL level. Occasionally, patients ask for more involved lipid profiles. These are called apolipoproteins. I usually don't recommend that because guidelines do not factor those into prescribing patterns or recommendations, and I think it just complicates things. Medicare will cover screening of cholesterol every 5 years. If you have if you have high cholesterol, they will cover it. They'll probably cover it every 2 years. I'm sorry, twice a year if you have high cholesterol. And then if you have another condition that increases your risk of heart disease or stroke, like hypertension or diabetes, they'll also cover it. But it comes down to kind of coding and getting it right. But if you just kind of order under Medicare a lipid profile and attach to a physical code, for example, Medicare's not going to cover it. And that's usually where it runs into trouble. And I go to great efforts to try to do this right at the get-go, but it's complicated. Plus, sometimes if I order it and then someone goes to a lab, whoever's entering that in the computer has to then also enter the codes, and sometimes I'm not convinced they get entered correctly either. So, it's not... Anyway, so there is a theme, though. When you get something not covered, you take a deep breath. I ask patients to get me a copy of the bill, and I'll intervene. And usually there's something. Medicare. I've been running into some trouble with screening for diabetes. So you could screen for diabetes in different ways. You could do a fasting glucose level. And Medicare seems to cover that, but a lot of organizations recommend a screening A1C. A1C is kind of like your average of how high your sugar is, and it's used routinely in people who have diabetes or pre-diabetes to monitor how they're doing. Whether or not it's a screening test, there are plenty of organizations who say it should be, and it's a good test. Medicare, I can't quite figure out. They do cover it, but they only cover it if there's risk factors. And I'm not quite sure what those risk factors are. And I've had a few patients where I have ordered for, and it has not really been covered. And we're trying to figure it out. Not fun, by the way. The day's busy enough.
Don't you think that's confusing for patients, though, that when the doctor says,
yes,
I don't know what those
absolutely
reasons are? I mean,
absolutely.
how come they won't tell you?
How come they don't tell me? They probably do in some book. Some tome that explains the rules. I have spent some time trying to look up Medicare's coverage guidelines for A1C testing for screening purposes. I can't quite find them. They say yes, it covers it with risk factors, but that usually doesn't get more specific than that. So I've tried to order it with obesity or overweight. Certainly the people who are at increased risk of diabetes, or I've attached it to another diagnosis of hypertension, but it still seems to be a problem. So I'm at the point now where I'm actually kind of not doing it. I'm just telling patients to go for a fasting glucose until I figure it out. Or if they insist, I'll say, look, I don't know if it's covered or not. So if you get this done, if it's not covered, you're going to have to pay for it. It's about $75.
Doesn't seem right.
It seems confusing, right?
I mean, if you don't know, who knows?
Yeah, that's frustrating to patients, and I understand. It's just complicated, and it makes the job a lot harder. Yeah, I will say that.
Right, because patients don't want their doctor in their computer. They want their doctor looking at them. They don't want.
That's part of it
but
too. Yeah.
They also want to leave the visit and have everything be covered.
when I'm ordering stuff in front of, I usually do it with the patient still in the room, and I explain to them what I'm doing. I said I am attaching code so this gets paid for. This is kind of what it is. I want them to understand that I'm going to great efforts to make sure it's done right, and I don't want them to get something not covered if it otherwise is covered.
Gotcha.
There are times where I tell patients something's not covered, and I want them to remember that. It happens a lot with men in erectile products, where I'll say, this is not covered, and I'll prescribe it, and then a form will come over saying, not covered, you have to do a prior auth, and that's another whole topic. But the prior auth is not going to be successful, so you get a little bit of like this catch-22 type mode where you're told to do something, but it's not successful, but you have to do it anyway and find out it's not successful, and then it kind of goes round and around.
So if I have no idea what a prior auth is, how would you, Reader's Digest, explain what a prior auth is?
Yeah. What is a prior auth? Because this is something that's really dragging down medicine. Okay, so if I see a patient, and a prior auth can either be for a test or for a treatment, a medication. So in the context of a medication, if I, for example, see someone and they have high blood pressure and I want to start a medication, and I choose a certain medication. And by the way, I go to great efforts also to avoid brand name drugs and use generics, almost religiously, because I believe generics are just fine in the great majority of cases. And I prescribe it. I'm doing like I'm writing it, which we don't really do anymore. Everything's on the computer. But in a way, that's the authorization, isn't it?
Well, you're saying a patient needs something.
Right. Well, I have the medical license. My license allows me to authorize prescriptions for people, and I'm prescribing, I'm authorizing it. For whatever reasons, although it's usually cost, even generics can be quite expensive, and there are other generic alternatives to generics that are cheaper. An insurance company might decide that something needs, they don't want to cover that right away. They want me to kind of prove it to them why the patient needs it, and then maybe they'll cover it, and that's called a prior authorization. So before they authorize the prescription, we have to go through this process.
Prove it.
Prove it.
So when you say they want you to prove it, then what is required of you?
My nurse does a great job with this, but there's usually a website they have to log on to. Varies from insurance company, or and enter the information and see if it gets approved or not. It happens a lot with diabetes meds. There's been some awesome new medications for diabetes that are great. They help people lose weight. They bring down the sugars. They seem to have cardiovascular benefit in the sense that they decrease your risk of heart disease. But guess what? They're new and pricey. So insurance companies are not in a rush to cover these. So they'll make us jump through these. They're also approved a lot for obesity, trying to treat obesity. And it can be it's probably the number one most frustrating thing right now, because you just feel like your hands are tied. And makes it very difficult.
Okay, we'll be right back.
Okay, thank you. Robin Baker and Dr. Eric Stanberg, Medical Monday. And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. It's Monday, March 14th, and 29 degrees now here in uptown Kingston. This last portion of Kingston Community Radio has been brought to you by Herzog's. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. And color decorating consultants are always there ready to assist you in interior design and choosing the right colors for your home. Visit Herzog's in the Kingston Plaza. We'll be right back after these messages.
Hey there.
What's up, bruh?
Hello.
Aloha.
Hey, y'all.
Hey.
Hola.
Hi.
It takes a lot of voices to create the sound of us, The Y welcomes all of them with open arms. From career readiness to safe spaces, the Y is there, no matter who we are. Now, more than ever, they need your support. Donate to your local Y today. The Y, for a better us.
Read by members of the Y.
Every 17 minutes, Make-A-Wish makes the impossible possible. They tame dragons. They bring Saturn to Earth. They help superheroes save entire cities. They even make unicorns fly. All to give children the strength they need to fight their critical illnesses. Every wish takes muscle. Help us make sure every wish comes true. Join us at wish.org.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio, so please keep listening and supporting our station.
And thank you for supporting Kingston Community Radio and listening to us this morning. And we are here every weekday. And tomorrow will be a terrific Tuesday. Wednesday will be a wonderful, let's see, what are we doing? Super Wednesday, okay? And a little bit about the weather and forecast for the next 3 days. Looking good, looking like spring. A high of 54 today with some sun and clouds mixed. And tonight goes down to 35 degrees, partly cloudy, then becoming more cloudy after midnight. And Tuesday, partly cloudy skies in the morning, giving way to cloudy skies during the afternoon. We'll go for our last half hour.